You know this is a Nestlé-sponsored symposium, so I also want to thank Nestlé for inviting me, and that's my conflict of interest. Although all the content of the presentation is my responsibility, I did all slides and I support everything I will say today. And the idea is to let you think about what you're doing with your orthogeriatric patients. Are you doing it okay, or can you improve? And what's the evidence that we're using for that? Why talking about a fracture in a geriatric, not an orthopedic congress? The reason, as most of you know, but some of the youngest here may not know or be aware, is that this is probably one of the true geriatric syndromes. Why do I say that? First, it has a high incidence, and an incidence that increases with age. Of course, it depends on the country. You can see here that in Scandinavian countries it's huge. Finland is here in between. Spain is low. But in any country, it's higher with old age as a consequence of osteoporosis. In fact, mean age of hip fracture patients is 80 years, and most of them are females, which is the profile of a geriatric patient anywhere in geriatric practice. Another issue is that mortality is still quite high. Mortality is around 20% in 1 year, and it's only slightly declining with years and with care, not rapidly declining. That means that 1 out of 5 of your patients admitted for hip fracture will be dead. This is more than your patients admitted for pneumonia or heart failure or most of other diseases, even cancer. So it's really a deadly problem. And these patients have other geriatric syndromes, which is common, clustering of geriatric syndromes, including delirium, infections, pressure sores, and many others. So these are complex geriatric patients, not simple fracture patients with a simple fracture. And in fact, it's not only mortality. We're related to work with function of people. Half of people with a hip fracture will never recover their former function at any age. This is quite a lot. 1 out of 2 will not, those who are alive will not recover the function. And they won't recover the quality of life or their previous health or the previous mobility. This is an example in many countries, and as you see, before fracture, during the fracture, and after the fracture, in most places, they never recover the baseline. So this is a real problem. Now you may think, but this is a malnutrition symposium. What are you talking? Well, let's think about that. Is malnutrition associated with hip fracture? And in fact, it is. This is a systematic review, quite recent, on the prevalence of malnutrition in these patients on admission to the hospital in the first 2 days. That means they come with a malnutrition syndrome before they are admitted, and that may have contributed to the fall and to the fracture. Well, mean age of these 9 studies with 160, more than 1,000 participants. It depends on the setting and the instrument you use, but from 4 to 28% of them using MNA, which is a fairly standard instrument, will be malnourished on arrival. And if you look at them later, when they go to rehabilitation, around 60% will be malnourished. So it's not only that many come with malnutrition, but many of them will be malnourished after surgery in recovery. You may now think, well, okay, these are 2 things to manage, but are they related or not? Is it bad to have both things? And evidence is too much to show in a single slide, because there are data that show that those patients with hip fracture that have coexistent malnutrition will have a high mortality, will have higher failure to mobilize in the first day, and you know this predicts mobility after hip fracture on the long term, will have functional dependence as consequence. They will also have impaired gait at discharge, so rehabilitation is more complex for them. They have a high risk of delirium. More patients with malnutrition will be discharged to a care home facility. And even more will have periprosthetic fractures, which is a real drama in many patients after hip fracture. So having malnutrition is terrible for an already bad disease in old age. It's a geriatric syndrome complicated by a second geriatric syndrome. This is a recent example, but I could show one or several for the previous slide. This is an example in 300 patients with hip fracture, where mortality is checked at 6 months. That's half of the one I saw. It's 11%. And as you see, one out of 4 well malnourished, and mortality is more than double. So the authors of this article say it's important to pay attention to nutrition. They will die and they will have more problems. And in fact, we have to start thinking of the food and nutrition of hip fracture patients from admission. I put this is one of many reviews, but I like the name. You were hungry and I gave you food. And I hope at the end of this symposium, when you see a hip fracture patient, you can think, you were hungry and I gave you food. That would be a nice conclusion. What happens with nutrition therapy? There are a couple of systematic reviews because there are many articles on the topic. This is a systematic review of 10 randomized controlled trials of nutrition intervention, more than 1,000 patients included. And this systematic review with meta-analysis showed that there's a significant reduction in mortality, in complications, and also in grip strength, which is in sarcopenia, predictor of functional outcomes, although the relevance of functional outcome is not clear. They say, this happens in many trials in nutrition, that evidence is low quality. And there's a lot of conflict on the quality of nutrition trials. But if you go and check what's the possible benefit and the risks of nutrition therapy, usually, even with low evidence, you have a high balance of, for using these therapies. But this is a geriatric congress again, so you will do orthogeriatric care, not just nutrition care. So we can look what happens with orthogeriatric care with different settings and models. This is, again, a systematic review, quite recent, in patients with hip fracture, and it shows that orthogeriatric care improves many outcomes. And this is all kinds, not the most modern, very active, proactive, geriatrician-led orthogeriatric care. It improves length of stay, mortality, delirium, and again, data on functional aspects are not as clear as before. I'm showing what's supposed to be the highest degree of evidence. That means meta-analysis of this intervention. So I guess orthogeriatric care is something you can convince your hospital director to introduce if it's not in your hospital, because it's now probably standard of care for hip fracture patients. And remember that any method of orthogeriatric care includes non-pharmacological therapies, and this includes, in all cases, proper nutrition and proper hydration. So what do this clinical guideline, the ESPEN guideline, this is the practical guideline, but it has the content of a guideline from 2019, so it's not old enough yet. It's on geriatric care, and it has a specific aspect on surgery and a specific section on orthogeriatrics. And in this section on orthogeriatrics, it recommends that older patients with hip fracture should be offered oral nutritional supplements during the hospitalization and after that. And see that it's grade A, because benefits are much higher than risks. And when it was voted by a full panel of ESPEN members, several hundreds, and it had 100% agreement. I think this is standard of care. So now you can start thinking, are you doing that? And in fact, what I like is the second part of the recommendation that says it's not only a matter of nutrition, it's a matter of full orthogeriatric care, and nutrition and hydration shall be embedded within full orthogeriatric care and part of it, which makes sense with the evidence I have shown. Now I'll use a couple of slides to show that this is not only ESPEN as nutrition organization. There are many countries producing guidelines on orthogeriatric care. because this is a serious problem and very expensive, very complex for healthcare systems. One of the oldest of the new wave of recommendations on hip fracture is this, which comes from Japan. And a couple of years ago, they said, we suggest enhanced nutritional therapy. So this is part of the standard of care. What about Italy? Italy has, again, a quite long and a comprehensive guide on how to manage hip fracture patients. And in Italy, they include assessment. So you need to check if there's something happening. And it suggests oral nutritional supplements assessment did in these patients, especially if diet cannot be appropriately changed. What about Canada? It has a full section on nutrition and says nutritional assessment is essential. Essential means something that any colleague that sees that you're not offering that would tell you you're not doing it properly. And the recommendation, again, is on nutritional supplementation, especially if there's no possibility to use a standard diet, with the recommendations of the PROTAGE group about increased amount of proteins in this setting. Norway. I have family from, my grandfather is from Norway, so I usually use that. All patients should be screened for malnutrition, again, assessment, and all patients should be served protein and energy-rich meals within an individual plan. So again, they are quite aligned. This is a very long guideline from one of the states in Australia, South Wales, and it's interesting to read if you're in orthogeriatric care. It includes many aspects, but it says post-operative orthogeriatric care includes assessment of nutritional status and prevention and management of malnutrition. And it's again very long, but it mentions dietitian assistance to help. If resources are limited, offer everybody oral nutritional supplements, because that's the way to warrant that you're giving proper nutrition. Provide multidisciplinary care, screen all patients, and refer those who need additional studies for malnutrition. Sorry, this is and apparently many are doing this. This is an audit from the hip fracture database in the United Kingdom. The audit does not mention intervention, only assessment. But apparently, this is coming into practice. At least we do screen in some countries for nutritional problems in these hip fracture patients. So if you're not doing this, you're one of the late comers in the field. So I will finish explaining what we do or should do when we do it properly in our department. We have a large orthogeriatric care. It's geriatrician-led. Geriatrician admits the patient and follows. The orthopedic surgeon comes and operates and checks the wound. After that, the rehabilitation doctor, other people come, but every day they are followed and discharge is decided by a geriatrician. And in this department, all patients are assessed for malnutrition using the MNA, which is positive in many, so we use the GLIM criteria to confirm malnutrition on admission. We check who are malnourished and include that in the diagnosis list. We're trying to include, which we have some problems with the screening with nurses, but also a screening of dysphagia, because these patients are laying a recombinant for a long time, so dysphagia in them is especially important to prevent aspirations. After that, we try to start intervention during hospital admissions. That means paying attention to diet, not having long perioperative dieting, nothing or no nutrition or hydration served. Hydrating by mouth and if not IV, but we need to have them hydrated. We review of those who are malnourished if they have causes for malnutrition, because malnutrition is a syndrome per se, where you have to look for the reasons, whatever diseases, drugs, whatever is there. We try to avoid constipation, which is a frequent reason in these patients for a reduced intake, and we offer routine specific oral nutritional supplement. What do I mean by specific? Specific means high protein, with proteins that are appropriate for this kind of patients, with essential amino acids, calcium, and vitamin D. These are orthogeriatric patients. And we offer that to all patients. based on the recommendations. On discharge, we recommend how diet should be and who should be enriched with proteins and calcium and all, but we also give the specific nutrition supplement for 3 months to all patients to be sure they don't become malnourished after discharge. And what we do is 3 months later, we assess nutrition status. And when we assess nutrition status, some patients will still be malnourished and will need additional workup for causes and individualized nutrition plan. Of course, this is done within orthogeriatric care. It's not a specific thing and the only thing we do. We do full orthogeriatric, but this is a nutritional aspect of that. So what is my summary? First, malnutrition is frequent. So you have to take it into your head, remember that, look for that, screen for that, because it impairs outcomes. And if it impairs outcomes in complex patients, that's bad for patients. The next message is that malnutrition can improve many outcomes at low risk. So malnutrition intervention makes sense as routine clinical practice. And we particularly recommend the use of supplements aligned with ESPEN. In fact, Dorothy is there, but I'm one of the co-authors of this guideline, so I couldn't do nothing different than the guideline. I hope we have time for discussion after the 3 speakers, but thank you for listening.